Everyone, present on behalf of Medicine One. This is the 74-year-old Mrs. K, who is a housewife from Vellore, has come with complaints of fever for 4 days, and she also has a complaints of headache for 2 days. So she was apparently normal before 4 days, and then developed complaints of high-grade intermittent fever associated with chills and rigor. There was also a complaint of headache, which is localized to the occipital region, and it is not associated with photophonophobia. Patient felt that she's having the neck tightness, and there is also complaints of generalized tiredness, which is not localized to joints. Complaints of nausea, not associated with vomiting. No complaints of seizures, loss of consciousness, or any paucity of movements. There is no history of recent vaccination or swimming in the ponds. Past history: she is a known case of diabetes mellitus for 1 year, and she was on metformin for the same. She is a known hypertension for the past 30 years. So general examination, she conscious oriented, she was vitally stable, and one positive finding is neck stiffness present. So this clinical syndrome: fever, headache, neck stiffness, so acute meningitis. So initially her WBC counts were 8,700 with a neutrophilic predominance of 77, and she has anemia of 10.9, and electrolytes normal, and bilirubin is 1.77, and direct is 1.29. And she has a transaminitis, which is AST is 162 and ALT 140. We have done a CSF, which has a CSF count WBC is 210, and it is neutrophil predominance of 71%, and it has a low glucose and increased protein. So culture CSF, there is no pus cells and no bacteria. So in the blood culture, the initial blood culture has grown as Streptococcus beta hemolytic, group B beta hemolytic streptococci. So initially she was on empirical antibiotics in meningitis dose, then it was changed to injection ceftriaxone 2 grams twice daily. So the patient is continued to have a severe headache. So we have initially thought of a differential, like there is any arterial occlusion like endarthritis, any arterial bleeding, or any cortical venous thrombosis. The patient does not have any focal neurological at that point of time, and she only complained of headache, like persistent headache. So now we have done an MRI brain, which has shown the features of acute ventriculitis and leptomeningeal enhancement, and no cortical venous thrombosis or hydrocephalus. And to see whether ceftriaxone is working or not, we have done a repeat CSF, which also has which has reduced. The counts were initially 260 and it was reduced to 140. So this is the ependymal enhancement which is seen in case of ventriculitis. So this white color thing. So what is ventriculitis? So it is a inflammation of the ependymal lining of the ventricles. It's a rare but severe complication of meningitis. So it is most commonly seen in infants, but can occur in the adults with certain risk factors like diabetes, immunocompromised, and if they underwent any procedures like head surgery, craniotomy, or neurosurgical implants. And our patient has a diabetes, no other risk factors like head injury, or she doesn't underwent any procedures. So is this group B, like this is like an incidental finding, or it's this group B beta hemolytic streptococci is associated with ventriculitis. So some points about Streptococcus agalactiaceae, which is the group B beta hemolytic streptococci. So it was initially found from Landsfield has isolated it from cow's milk and bovine mastitis. It's a normal colonizer of a genital and gastrointestinal tracts. So this is a classification of streptococci taken from Harrison. So group A is Streptococcus pyogenes, and group B is the Streptococcus agalactiaceae. So the most common infection we are seen in literature and in the books are neonatal sepsis and meningitis, and puerperal infection in the pregnant woman, and urinary tract infection, rarely endocarditis. So this Streptococcus aglutatiae can cause cellulitis, bacteremia, endocarditis, and meningitis. Rare complications, sometimes it can cause ventriculitis also. So why this is very important means if you are not like prompt recognition treatment is important because the mortality rate is up to 66%. The patient has a ventriculitis. So now in like nowadays from the active bacterial core surveillance, so there was an increase in cases like 8.1 cases per 10,000 to 1 lakh in 2008 to 10.9 cases in 1 per 1 lakh in 2016. So we have done like to rule out the two complications like infective endocarditis along with ventriculitis. We have done a echo. It was done to rule out vegetations. So she doesn't have any vegetations. And to rule out the source of GBS, we have sought a dental opinion to see any cavity or anything she has. She doesn't have the same. And we have planned for a gastroscopy and colonoscopy to rule out GI source of invasive GBS. And she also, we are like her blood-borne viral screen was negative and HbA also 7.9. So as of now, her predisposing factor is diabetes, but we have to wait for the gastroscopy. She doesn't have any GI symptoms as per se. So any occult malignancy can cause the GBS from the colon to invade into the blood. This is a case which has both meningitis and ventriculitis along with endocarditis. There are two, three case reports like this has a co-infections. So my landing point is we have to look for the cause of invasive GBS to prevent the recurrence, as the recurrence rate is 4%, and we have to, as the increased rate of mortality to 56% in associated ventriculitis, and it will also change the course of antibiotics. So for our patient, we plan for 6 weeks of ceftriaxone BD. Thank you.
Thank you, Dr. Monica, for taking time. We have time for questions now.
I think this complication could have been easily prevented now because you could have given. There is a conditional recommendation before giving the first dose of antibiotic to give dexamethasone for especially pyogenic meningitis.
So initially we have given dexamethasone and after
recommended is 0.15
0.1
for at least
0.15 milligram per kilogram. So there are four if the patient has a CSF count are more than 1,000 and if the gram strain is positive and if she has like pneumococcal or anything. So as these things are not there, we have stopped it after 2 days.
Do we have a long-term follow-up with this patient?
Yes, sir. She is getting followed up in the LCCU. She recently came to see us also. She was clinically very well and headache is not there. Her neck stiffness, everything was improved. Initially, she was bedbound. Now she was walking and she was well and good.
She is doing well. She was there for the initial 10 days. And now she's completely with this patient till August 3rd.
August 3rd.
That's right. So she's well.
It's nice. Do you think the diabetes was the main factor?
For her, the only respect and
7.9 HbA1c with that.
But she requires insulin in admission. So discharged in insulin also.
Any other questions? Anyone online? Right. Thank you, Dr. Monica. And we move on to the next case from Medicine 2. Black syndrome being presented by Dr. Lakshmi.